Hello, everyone. My name is David Lee, and I'm a soon-to-be MS4 completing a research year under the mentorship of Dr. Kirane, and it's an honor for me to be able to present our research today here at Holman Day. I have no disclosures to report. So the management of stage 2B and 2C melanoma is highly controversial, and this is an incredibly high-risk population that is at risk for metastases and melanoma-related death with standard of care surgery alone, which consists of a wide local excision and sentinel node biopsy. Immune checkpoint blockade was recently approved in this high-risk cohort. However, there only is a single-digit improvement in recurrence-free survival. And in addition, there are a plethora of immune-related adverse events that can occur in these patients. Also, there are no biomarkers available that allow us to stratify these patients into appropriate treatment classes. And so thus, what we did was we piloted using an alternative oncolytic virus-based approach using TVEC, which we inject directly into the tumor. And this will allow us to generate a systemic immune response with less off-target effects compared to systemic immune therapy. And second, we aim to contextualize a novel biomarker assay before and after therapy. So our group hypothesized that the different patient responses to oncolytic virus can be attributed to the innate immune cell milieu or the myeloid populations, which are typically underreported in previous TVEC trials. And in addition, there's a small body of data suggesting that patients that respond to immune checkpoint blockade and oncolytic virus have different profiles. And our group believes that patients that do not respond to TVEC typically have a more immunosuppressive tumor immune microenvironment. And so what we want to do is we want to generate a biomarker by looking at the functional engagement of different immune cell players in order to help us get closer to that goal of creating a good biomarker for these patients. And so when I talk about functional engagement, I'm talking about ImmuneFRET or IFFR. And so this is an assay developed by our partner, Dr. Laranjani at the University of Bath. And what it does is it uses a coincident time-resolved energy exchange mechanism across the ligand receptor pairs, in the case of our study, the PD-1 and PD-L1 axis, to quantify the strength of the interactive state. Importantly, this can resolve inter and intracellular signaling at the nanometer range. And this metric serves as a chemical ruler to precisely measure if the ligand receptor complex are in range to be actively engaged with much higher precision than typical co-localization assays on the market. This approach has been validated in multiple immunotherapy-treated tumors. As you can see here by these Kaplan-Meier survival curves, this PD-L1 FRET is a more sensitive predictor for overall survival compared to PD-L1 expression alone, which is a conventional biomarker that failed to stratify patients appropriately. Surprisingly, and also there's significant heterogeneity in the tumor tissue in regards to PD-L1 FRET. And surprisingly, in the case of the non-small cell lung cancer samples, there's a negative correlation between the CD8 positive T cell infiltrate along with the PD-L1 FRET, which is counterintuitive, and thus this assay warrants further investigation. And so what we did was in our study, we looked at pre and post checkpoint changes using this technique. But first, I'm going to go over some data from our trial. And so here is an example of a complete responder's lesion over the course of oncolytic virus therapy. And here you can appreciate the regression of the tumor. And when we look at our patient cohort, we can see that it's divided into 1/3 complete responders, 1/3 partial, and 1/3 non-responders. There were no major adverse events, with all patients experiencing only grade 1 fever in the 24 hours post-injection. And all patients completed surgery as planned without any surgical complications. In addition, only one of our patients experienced relapse despite being a very high-risk cohort overall, who was a non-responder patient and our only positive sentinel lymph node. Next, we looked at conventional biomarkers of response to oncolytic virus, CD8 positive T cell infiltrate in the tumor, and PD-L1 score, both considered to, on average, increase in response to oncolytic virus therapy. We found that both pre-treatment and post-treatment values for these biomarkers displayed wide heterogeneity when we look across all of our patients. And there was no consistent patterns either at baseline or in the post-treatment shifts related to response status. However, lending credence to our original hypothesis regarding the myeloid cell populations, we looked at the tumor-associated macrophages in our patients, and we can see here that the patients that responded to our oncolytic virus therapy had a higher inflammatory tumor-associated macrophage population, or M1-like macrophages, that significantly increased in response to oncolytic virus therapy. And when we look at our metastatic and non-responder patients, we can see that they have a more M2-like macrophage or immunosuppressive macrophage profile without any significant shifts on therapy. And meanwhile, our partial responders had more mixed profiles, and we're currently looking at these divergences using nanostring to look at additional cellular and genomic factors that can explain what's going on. And we used, and here's our IFFR data for our TVEC patients at both the pre and post-treatment time points. And so when we look at our complete responders, we can see that based on the physical parameters of our assay, we can see that they start off with a very low PD-L1 FRET or near zero based on the physical parameters of our assay, and then had a significant increase over the course of oncolytic virus therapy. Meanwhile, when we look at our non-responder patients, we can either see a decrease in PD-L1 FRET or no change from a zero baseline. When we look at our partial responders, we again see a mixed profile, but there was a second incidence of decreased PD-L1 FRET after TVEC therapy, which raises very interesting biological questions that may eventually answer why TVEC was not very impressive in the phase 3 clinical trial setting. And one of those questions that we pose is whether or not a patient with a high starting PD-L1 FRET should be given upfront anti-PD-1 therapy instead of oncolytic virus. And so putting all of our data together, as you can see here on this very loaded slide, when we look at our complete responder patients, we can see that they have a very high PD-L1 FRET after the administration of TVEC. And what's really interesting about this is that these patients don't have any tumor left after TVEC, they're complete responders. However, when we look at our tumor-associated macrophage data, and we see that these patients have a more pro-inflammatory M1-like macrophage profile. And based on the ongoing studies that we're performing in the lab, where we're seeing that there's PD-L1 expression on the macrophages as opposed to actual tumor cells in the melanoma tumor microenvironment, we believe that the macrophages can be the key to the results that we see here in our IFFR data. And so therefore, we think that IFFR may deserve further classification of whether this activity is across the antigen-presenting cells and T cells, or tumor cells and T cells. And of course, we want to see if there are other contributors of PD-1 in addition to the CD8 positive T cells. And so in conclusion, we're now utilizing Dr. Laranjani's spatial IFFR mapping called the FuncoMap in conjunction with our LUNA4 multiplex immune assay. And this will allow us to enhance our ability to identify cellular participants in high PD-L1 FRET areas of the tumor. We're currently building the FLIM microscope technology, which is the microscope that allows you to precisely look at PD-L1 FRET on these tumors so that we can perform our own biomarker stratified clinical trials here at Stanford. Our preliminary data is promising and supports further analysis of comprehensive immune profile in tumors. And we really believe that we're on the cusp of discovering a biomarker that allows us to successfully stratify patients into appropriate treatment classes. Preliminary insights suggest that neoadjuvant intralesional therapy could be a lower risk, effective immunomodulation strategy in melanoma, and our data hints at a subset of patients who may not benefit from upfront immunotherapy, but may benefit from upfront surgery alone. And so I'd like to thank my mentor, Dr. Amanda Kirane, and the rest of our members of the Kirane lab for just being igniters towards my dream of becoming a surgeon scientist. And I'd like to thank the rest of our collaborators and their expertise in helping us to complete the study. Thank you so much.